Hello, my name is Professor Ravi Gupta. I'm Professor of Clinical Microbiology at the University of Cambridge. And my talk today is going to be the impact of variants on SARS-CoV-2 efficacy. Here are my disclosures. So we realized sometime last year, probably around the middle of 2020, that the global mutation rate for SARS-CoV-2 was something like 2 mutations per month. And this relatively low mutation rate was probably due to the very short incubation period of SARS-CoV-2 infection and the fact that much of transmission was asymptomatic. In other words, the virus produces an infection in the upper airway and then the lower airway and transmits very soon after the initial infection. And in this case, you can imagine that there is little opportunity for the adaptive immune system to exert any selective pressure on the virus. And that's why you observe these transmissions with very, very few mutations. We refer to this as a hit and run infection paradigm, where there's rapid cell infection and turnover. And all of this combines to a relatively low selection pressure for this RNA virus. However, later in 2020, we realized that there was a phenomenon of chronic infection with SARS-CoV-2, lasting weeks and months. The longest recorded case is well over 200 days. And during that time, the individual is productively infected, the viral load is variable, and there are a number of reports in the literature that show accumulation of drug resistance or immune escape mutations. So in large part, these are often driven by immune selective pressures. We can see changes in the spike protein. As you can see here on the top, these are spike residues, T240I, 200, D796H, 6970. These are all spike mutations that we observed in an individual who we followed over a period of 4 months. And there was a shifting in virus populations during that time. And this and other reports demonstrate essentially that within a chronic infection in a patient, you can observe the kinds of mutations that we are observing in the new variants. So here are the 3 main variants of concern. Of course, there are other variants of under investigation and of interest, but here are the 3 main ones. The first is the B117, otherwise known as the variant that emerged in the UK. And in this spike representation, you can see the mutations which define this variant. There are in total 23. And there is the N501Y mutation, which has been shown to increase ACE2 binding and also has a small effect on antibody evasion. There are also 2 deletions in the NTD and then a number of other S1 and S2 mutations. So this emerged towards the end of last year. One of the ways of studying such viruses in terms of what their impact on vaccine efficacy is going to be is to generate pseudotyped virus particles. And this is an HIV meeting. So of course, we're all very much used to seeing these sorts of data as we've been pseudotyping HIV for a long time. And this has been a very good tool for studying mutations in SARS-CoV-2. So essentially generates HIV particles, which are pseudotyped by co-expressing plasmids with the S protein from SARS-CoV-2, and you can make different mutations, as you can see here, in that spike protein. And this Western blot shows you expression levels here in the supernatants, and you can see the P24 in the HIV particles down here. So this is a very useful tool for measuring neutralization by antibodies, and we generate IC50 curves just as we do for HIV drug resistance assays. So what is the impact of B117 on vaccine efficacy? And the way to test this is to people have generated pseudotyped particles bearing the B117 spike and its 8 mutations. And they have made serial dilutions of serum from people vaccinated with different vaccines. So you can see, I've just given 2 examples from many, many papers that have been published. Here, this paper looks at the Moderna Novavax vaccines, as well as some convalescent sera from people infected with the pre-B117 viruses. And you can see here that the serum titer for D614G parental virus, or the B117 is shown, and you can see there's a loss of neutralization that is relatively modest for the B117, so between 2- and 3-fold loss of neutralization here. And on the bottom panel, you can see here that there's a panel of neutralizing antibodies that have been tested against the B117 and D614G. And again, you can see the B117 is less sensitive to certain monoclonal antibodies. In a study we published earlier this year, we found a similar story around a 2-fold loss of potency of neutralizing antibodies against the B117 when we considered the Pfizer vaccine. And you can see here some representative curves from monoclonal antibodies. And the take-home message here is that most of these monoclonal antibodies down here on the bottom maintain very good neutralization titers against B117. So B117 appears not to have a dramatic impact on the ability of neutralizing antibodies from a range of vaccines to neutralize B117 bearing spike pseudotyped viruses. What about the real world? Well, here a number of studies have been performed and real world rollout data. For example, the Pfizer vaccine shows 90% efficacy in studies that were undertaken in Israel in rollout. In the pre-VOC era, the clinical trials showed 90 to 95% efficacy. There is very few data from Moderna against new variants. Novavax against B117 shows 86%, so very little difference from pre-VOC viruses. And similarly with the ChAdOx vaccine, 75% protection compares very favorably with a 62 to 90% protection in the clinical trials from the pre-VOC era. Data from the J&J vaccine show reasonable protection against pre-VOC viruses, but there aren't much in the way of data against B117 viruses. But the important thing to note here is that B117 is still evolving. You have here the green, these are B117 viruses in the UK. And these red ones have acquired E484K. This has also happened in other countries around the world, for example, the United States. And this, this graph shows you what happens when you have the E484K on top of B117. And this is a picture showing you the potency of monoclonal antibodies. You can see here in red is the E484 bearing B117, and here in blue is the non-E484K. So you can see the E484K confers reduced susceptibility to a range of antibodies targeting the receptor binding domain, as would be expected. And so what happens to the fold changes for the for vaccine sera? You can see there's almost a 7-fold loss of neutralization potency for the E484K bearing virus relative to B117. And for convalescent sera, that's more than 11-fold. So E484K is something to worry about when it appears on B117, as well as other viruses. So moving on, now that we've just discussed E484K, this mutation is present in both the B1.351 and the P1 viruses from South Africa and Brazil, respectively. Many of these are disseminated around the world. They both have mutations at position 417, and so this trio of residues has caused some concern because of their interactions in the receptor binding domain. So we'll now consider the effect of B1.351. This figure on the left shows you that if you take the virus and place it in the context of convalescent sera, you get almost half the patients who have lost all neutralization of that virus, as opposed to almost full sensitivity here against pre-351 viruses. If you take just the receptor binding domain, you get a quarter of them completely lose response. And so this suggests that it's not just the RBD that is responsible for reduced vaccine efficacy in the B1.351. Sorry, convalescent plasma efficacy. Here in this table, we're just showing you that there's a difference in heterologous neutralization between first and second wave serum plasma from South Africa, suggesting that if you're infected with the V2 variant here, you can cross-protect against the initial strain, but not vice versa. And that's really important. Moving on to data for B1.351 and P1 from another study against, this time we're using vaccine sera against Pfizer and Moderna elicited neutralizing antibodies. You can see here that the 1.351 has quite a significant decrease, fold decrease in neutralization potency, and the Brazil P1 variant you can see here is intermediate between the 351 and the B117 originating in the UK. So you can see a stepwise progression between B117, P1, and then the B1.351. So what about real world data from 1.351? Well, for Pfizer, there are very little except for a case, a case series or observational study from Israel where they showed the odds ratio of 8 for being or presenting with SARS-CoV-2 infection in the context of having a previous vaccination with Pfizer. So you're almost 8 times more likely to be infected with a 1.351 strain if you had had previous vaccination. Novavax study showed 50% protection in South Africa as opposed to 89% in pre-VOC conditions. So there is certainly a drop off there of efficacy. And the most famous sort of example of loss of efficacy is this Mardi et al. Study from NEJM in South Africa, where there was only 10% efficacy of the Chadox vaccine in South Africa. And this really are important data suggesting that this virus can escape neutralizing antibodies. However, in this study, there were virtually no deaths and very few severe infections. So there is still some protection, we believe. The J&J vaccine was just reported as showing around 64% protection in South Africa, which is very, very encouraging. What about P1? Well, there are very few data for P1, and we really do need to gain some more information. The only data I could find was from CoronaVac and Sinovac study conducted in Brazil, which showed a 64% protection against infections in Brazil, the majority of which will have been P1. Important to realize that there are age-related heterogeneities in responses, and we've done this study recently showing that if you're over 80 years old, you have a reduced response to vaccine-elicited antibodies, and this is more marked if you have a B1 against B117 than it is for wild type, as one would expect. And as you can see here, over time, that there doesn't appear to be a difference in those who are presenting almost 3 months after their first vaccine. You can still see a 50-50 split in neutralizers versus non-neutralizers. As you can see here, early after the first vaccine, within 3 weeks, there's still a roughly 50-50% split. This argues against increasing vaccine responses over time, and as has been suggested for the Chadox vaccine. So if you extend the dosing window to 12 weeks, people will be vulnerable if they're in the over 80 category here, as you can see in red. People who are under 80 here in blue are mainly good neutralizers. As you can see, most of the blue dots here above the neutralization line. So what about the B617 Indian variant? Well, I'm going to skip through this. There are two different lineages in the main with E484Q defining point 1, and then the point 2 has lost E484Q and instead has a T487K mutation. Both of these are combined, of course, with the L452R RBD mutation. We've recently reported online, but in preprint soon, hopefully, that the E484Q has a more modest effect than the K at that position. And that's reassuring. And more reassuring is the fact that when E484Q is on top of L452R in the RBD, that the loss of neutralization is still around the 4-fold mark. So again, moderate. So this argues against calling this variant a double mutant, importantly, and we need to understand more about the biological processes underpinning this. So in summary, I've shown you that B117 shows modestly reduced susceptibility to vaccine-elicited sera. Potency is greater after the second dose, and the real-world efficacy of pretty much all vaccines against B117 is high. However, we are observing escape mutations such as E484K on top of B117, and we should watch for that. The B1.351 virus that's emerged in South Africa, we think, shows the highest degree of immune escape in vitro and in the clinic, but this virus is still sensitive to vaccine responses in that there is protection from severe disease and death, and that's important. We still need more data on P1, but in vitro, it appears to have intermediate loss of sensitivity, so less to worry about, but we do need more clinical data. And the newly emerged Indian variant, B.1.617, also appears intermediate, though we do need more clinical data on this. And I would just end by cautioning against extending dosing schedule, especially in the elderly, because immune responses can be suboptimal, and that needs to be taken into account. I'd like to also just address some future challenges. We will probably need a yearly vaccine update, but of course, the mutations included in the new vaccines are to be debated. There's a big question about access to vaccines, as we all know. We need to understand when we're going to boost, because we can't simply boost everybody at the same time. I think we need to have a more tailored approach, and how do we measure the correlates of protection to inform that? And then finally, of course, the big question of T cell versus B cell immunity needs to be further established when dealing with variants. I'd like to acknowledge my collaborators and also thank you for your attention.